Thank you for the invitation. So we're going to talk about something, as vascular surgeons, we don't do that often, and not many vascular surgeons do. These are my disclosures, not relevant here. So once you start getting into the arch, you're going to have increased pressure, migration. We have to deal with the coronary arteries, dealing with the aortic valve. The patient had a mechanical valve. You have to go through it, make sure you don't cause any trauma, even in a normal valve. Sometimes you have to actually have wires, so maybe part of the device in the left ventricle. And again, in many of these cases, you actually need the cardiac service center or cardiologists come here, help you, and do some rapid pacing so you can deploy these devices. So as we're showing, the aortic arch, and what are our options? Some of them we need our partners from cardiac surgery. Sometimes we can do by ourselves at this point. Of course, depending on where you're going to need your repair, your options are going to be debranching from cardiac surgery, TBAR. That's how we started a long time ago. Laser has become popular over time, but now we have some fenestrated and branch devices, some of them FDA approved, and the other one in the process of being approved. So just simple, starting on the branch and options. Patients can have a carotid subclavian bypass. It's going to be the most common surgery we do to actually land in zone 2, carotid bypass, and carotid subclavian. That's for some of the devices we have available right now. And then you have the ascending arch bypasses and just a TBAR. That's how we started a while ago. As I was saying, the most common requires is a left subclavian artery. On the other hand, in acute aortic pathologies, most patients can tolerate the left subclavian covering without revascularization very well, but you need to pay a lot of attention. A partner of mine doing an acute dissection malperfusion was very close of covering the left subclavian until one of my other partners walked in and realized, there were some wires in the chest. This patient had a lima to LAD, and they realized the patient had, of course, had to land distal. You need to look at the vertebral artery arising from the arch. Patients with left upper extremity fistula, not only because you might lose access. After you cover the subclavian artery, the patient's going to develop steel. That happened to me in one of those patients, and doing a bypass later on and every vein is bleeding is not very nice. Of course, you need to check also on dominant left vertebral arteries, and you're also looking in to make sure it does not end in pica. And as they were talking earlier, we should always revascularize the left subclavian artery in elective surgery. This is showing the left side innominate artery. You see the left common carotid artery. This patient by partners in cardiac surgery had a bypass. You have the mark, you do a TBAR. Now let's go to laser fenestrations. Gene Panetton published quite a bit about this, and he published his experience on emergent aortic pathologies on 60 patients. Most of these patients were in zone 2. And he found, in a follow-up of 2.4 years, you're talking about acute aortic pathologies at a significant mortality of 8%, stroke rate, and we're going to see in every paper going from 3 to 6 and sometimes higher. Every time we get into the arch, we need to be extremely careful manipulation because the stroke rate is a real problem, even with good technique. But again, in this paper, he showed that in this follow-up, he has 100% patency, some 3 type C endoleaks, but it shows to be safe and durable. This is just an example of one of these cases with a previous debranching. As you can see here, cardiac surgeons did a nice job leaving me a mark. I have a sheath from the arm. Very important when you do a laser fenestration, you need to get a lateral view, as you can see here, and then you have to look down the barrel, make sure you're not skiving it. When you do a laser, you put the laser through. I used a 2.3 millimeter that you can put an 035 wire, balloon it with a 4-2 balloon, and then put the stent appropriately sized to prevent that type 1C endoleak. Now, for a couple of years, we had a Gore TBE. Hopefully, most of you have done this device. It's a very nice device with it's a 1 retrograde branch. You have the side branch that's standard is 6 centimeters, and you have some proximal cuff, and you can extend distal as well. Most importantly, you need to look when you measure for these devices. You need to look out the outer curve. If you look at this as a number, let's say this is the left subclavian artery, this is the carotid. You measure from the middle of this for the distal, and then you're going to see where should actually, what length device are you going to get. They come in 2 branches, 8 millimeter and 12 millimeter. 12 millimeter is going to be, of course, for the zone 0. And again, it's always good to have a rep measure for you, but it's very important you that are in training right now, measure things yourself and use them because they're going to be able to teach you. Again, you have different size stents for depending on the portals, and they're all 6 centimeters long. Just briefly, you're going to put Landoquist into the ascending aorta. You have a through and through wire. The through and through wire you put on the side port here. I like to get a left radial access with a 4 French 75 sheath. You go ahead, advance the device. It's never going to look as nice as this, but you need to make sure you don't have wire wrap. It's very important when you have wire wrap that you don't just go ahead and turn it there in the arch. You move it back, you turn one way or the other one. That's probably one of the most frustrating part of these cases. But once you're actually in position, deploy the graft, you come through the through wire, you get the 4 French sheath from the arm, pass the portal down, you merge it with your stent to make actually, and you pull from the arm while you're pushing to make sure the stent goes in. Well, you take your image of this vertebral artery and the stent is deployed. It's a pretty straightforward device, tell you the truth. So midterm outcomes only on 40 patients here, most of them on zone 2. They had no migration, fracture, rupture, 2 occlusions asymptomatic on zone 2, and freedom from intervention 97, zone 2 and 100. In zone 1, they have 1 type A that was required as zone 0 TBE, and 1 type 3 not treated because there was no growth and the patient had 2 strokes. Now into more important data here, looking at treatment of acute aortic pathologies. This now we're going to 107 patients, most of them dissections, symptomatic aneurysms, and blunt aortic injuries, most of them in zone 2. Again, with a good group of people in this publication, technical success of 99%, 30-day mortality 2%, very good actually for acute aortic pathologies. But again, stroke 6%, paraplegia 6%, and this is interesting looking at 5% retrograde dissections. All of these were in acute and subacute dissections. I have only used this device in subacute dissections, but we always have to think, how much manipulation are we going to go? Are we going to go with a device, have a wire wrap, going back and forth? Even though all of this, I don't know if there was damage or not, most of this, all of these dissections happen after 30 days. So I don't know if it's related to this or just the pathology. And mean follow-up, again, short follow-up, 55 days. There was 7% 1 or 3 endoleak, 1% branch occlusion, and 7% reinterventions. You expect this from any device. Now, a different device that actually is very different than anything we do here, to tell you the truth. I did only one of those devices. It was an interesting experience. It's a Nexus device that finished the clinical trial. They're submitting now, and they're hoping to be FDA approved at the end of next year. So you have the main device, you snare from the arm, and it deploys from the innominate down, and then you go ahead and you put the proximal piece into zone 0. You have a 2.5 centimeter overlap, and also has some locking latches. Just going fast through this video so you understand. You see this deploying into the innominate. This is the opening where you're going to then go with the ascending graft, and now you need to push. This is very different of anything we do. Once you push, now the innominate stent is in position. You keep on pushing and deploy the rest of the device, and then you go ahead and place the ascending component of this device. So again, this is the clinical trial of Nexus 1. It's an off-the-shelf device. Again, hopefully they're going to be FDA approved next year. If that happens, they're planning to have a custom with 2 and 3. They don't know about it. These 2 are available in Europe at this point, but not in the US. What's their experience with the device? Again, not that many patients, 28 patients, 100% procedural success, most of them aneurysms, 20% dissections, 30-day mortality 7.1%. Again, stroke, every time we get here, 3.6%, and reintervention 10%. Just briefly, this device is only available as a compassionate use right now. I was part of the feasibility 6-7 years ago, but it's and they're going and they're going to redesign this device. But again, it's 2 branches for the innominate and the left common carotid artery. There's a 50 millimeter opening, and actually you stand into all of these 2 devices, and I have to say they had the most awkward side branches, 14 French sheath, and you have to come from the carotid artery. It's like putting a CSLE limb and you're going from the carotid artery. I'm glad actually they're redesigning this device, and this is just the first device. Again, this was 6-7 years ago, and we are still waiting. Now going to the Cook device. It's a Cook A branch. This is only available part of IDs here in the US. It is very nice. There's a pre-curved sheath. You don't have to worry that much about orientation. You can have 1 to 3, actually even 4 branches, antegrade and retrograde. And this is a 3-vessel branch, and this is nearly off the shelf. But in this case, it has innominate artery branch here. You see the diamonds and the marks, left common carotid artery, and a retrograde branch for the left subclavian artery. It has a catheter in there. And this is a case actually I did last week. A 60-year-old gentleman who had a previous ascending, then a root. My partners from cardiac surgery, they're supposed to do a thoraflex. They said it was impossible. After I spent 10, 11 hours in the operating room, you don't see this very well, but there's going to be a dissection here. I'll have the CAT scan, dissection in the nominate, dissection in the left subclavian artery, bovine arch, and a dissection in the left subclavian artery. Looking at the CAT scan here, it's going quite fast, but you see the common carotid artery with some calcium and dissection sense over there, innominate, and the right subclavian artery dissected. Left subclavian artery is dissected as well, 6 centimeter aneurysm, and a dissection going all the way down. This took me a while actually to figure out what to do with this case, but this is a plan that had 3 different stages. This patient I ended up doing, since it's a bovine arch, I didn't want to have 2 branches going through the nominate. I ended up doing a left subclavian to carotid bypass, so then I will stent into the subclavian and have flow through the bypass into the carotid artery. At the time of the arch branch, I did a right carotid subclavian artery, and to be able to do it pretty high, to be able to stent retrograde into the 10 millimeter branch that is antegrade. And step 3 that I still have to do a septotomy and a TVAR for distal seal. As you can see in this case here, I have a 10 French sheath coming from the carotid artery, marking the nominate. The graft is deployed. In this case, I put a 13 Biovan into the common carotid artery, and then a retrograde stent into the left subclavian artery, then going through the carotid subclavian bypass. This patient luckily did very well. Of course, as I was mentioning earlier, very concerned about stroke when you do so much manipulation and surgery. Now looking at this device, this is published a couple of years ago with 3 vessels on the A branch. There were only 39 patients, 36% degenerative and chronic post-dissections in the rest. Again, this is an experienced group. They had 100% technical success, but again, there's still 5% hospital death, 5% stroke, 3% secondary intervention. But again, these were very reasonable results if you look comparison of doing these high-risk patients in open surgery. So in conclusion, we have new technologies with promising results. Again, techniques require proficiency. Patient selection and planning are key. Again, procedural stroke remains a significant issue, and we require long-term outcomes to assess durability. Thank you.
Thank you, Ezequiel.